Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Pneumonia is a common diagnosis in the ICU. In today's podcast, we will discuss different aspects of managing pneumonia in critically ill patients. We will cover the initial management of severe pneumonia, discuss management of ventilator-associated pneumonia, and then cover the clinical approach to non-resolving pneumonia in the intensive care unit. Our guest is Dr. Kalil, a physician specializing in critical care and infectious disease. Dr. Kalil is a professor in the Division of Infectious Disease and director of Transplant and Infectious Diseases at the University of Nebraska Medical Center. A renowned clinician, educator, and researcher, Dr. Kalil has received numerous distinctions, including the 2021 Scientist Laureate Award at the University of Nebraska Medical Center. Dr. Kalil is a prolific author and has participated in several IDSA and SECM clinical guidelines and has written extensively on the topic of hospital and ventilator-associated pneumonias. His most recent paper is entitled How to Approach a Patient Hospitalized for Pneumonia Who is Not Responding to Treatment. Andre, welcome back to Critical Matters.
Thanks so much, Sergio. I mean, it's really a true pleasure to be here back with you, and thanks so much for the invitation. I'm looking forward to talking to you.
And like you said, before we started recording, this is a very broad topic. We could spend hours, so we're going to focus on some practical aspects. But as we start, I would like to ask you, why should intensivists care about this topic?
Yeah, no, it's a great question, Sergio. I mean, I think that's very important for everyone working in the ICU today. Realize that there is no infection more common than pneumonia, being the reason to be admitted to the ICU in the entire planet. It is really quite common, no matter where you live, which country you live, which continent you live. Pneumonia is going to be your most common infection coming to the ICU, and also, not something to forget is the fact that pneumonia is the number one cause of sepsis in the world. So the point is, knowing that sepsis is killing 49 million people every year in the planet, and knowing that the number one cause is pneumonia, I mean, I think that really should give pause to all of us working in the ICU to believe that the more we know, the more we learn, the more we know how to manage these patients, the more lives we're going to save. So pneumonia really, it is a critical topic for us to grow and learn and to do better.
And as every topic that we discuss in life, but also in the ICU, even though it's something we see commonly, it's an onion with many layers that we'll try to peel today, correct?
Absolutely.
Could we go over definitions of the types of pneumonias that we might see in the ICU and why that's important?
Yes. So, the definitions have evolved a little bit in the last few years, and I think that's a perfect timing for us to talk, Sergio. The definition of CAP in general, community-acquired pneumonia, remains relatively stable in the sense that it is an infection that affects the lung parenchyma, and it is caused in some place outside the hospital setting. So, basically, it is a patient that already come and is admitted to the hospital with a lung infection that was acquired before the patient was hospitalized. So that's relatively straightforward, and in the sense that definitions have not changed too much. Now, what's not so straightforward is that the amount of things that can cause community-acquired pneumonia are keep growing. So, we saw a few years ago during the pandemic, so different viruses like SARS-CoV-2, different strains of influenza. Now we're seeing a respiratory syncytial virus. So the point is, pneumonia is really not caused just by bacteria. It's caused by fungal and viral and parasitic organisms. So we are seeing expanding number of etiological agents that's causing a CAP, and sometimes that can bring some confusion to the definition of CAP. HAP and VAP have evolved as well. Years ago, they were lumped all together. Everything was anybody that acquired a lung infection in a hospital, especially being in a hospital for more than 48 hours, were pretty much labeled as either a hospital-acquired pneumonia or ventilator-associated pneumonia. But with the last guidelines, in which I was one of the co-chairs, the IDSA, American Thoracic Society guideline done in 2016, we decided to make the definition a little more refined, a little more practical in the ICU as well. What we did is we separate HAP and VAP in the sense that you could have a HAP that end up with intubation. You could have a VAP that really was not born of a HAP. So this is getting a little bit confusing because there's so many abbreviations here. But let me just try to explain a little more specifically. So hospital-acquired pneumonia is defined as infection, a lung infection acquired when the patient has been more than 48 hours in a hospital. So that's possible that so in that case, could be that the patient is developing HAP without the need for intubation, or the patient developed HAP, that means got infection before getting intubated, end up needed the intubation after being diagnosed with hospital-acquired pneumonia. So that would be a HAP that was subsequently needed to be intubated. So basically, it is still a HAP, but now the patient has mechanical ventilation. Ventilator-associated pneumonia is a situation in which the patient develops a lung infection that requires mechanical ventilation or invasive mechanical ventilation, and the patient develops an infection 48 hours after being intubated. So the bottom line here, it's a little bit different in the sense that now the patient got intubated for multiple reasons, not for infection, and now 2 or days later, the patient develops a new lung infection. So this is going to be called ventilator-associated pneumonia. One thing, Sergio, if you allow me, I want to talk about is that there was, before our guideline being published in 2016, the HAP-FAP guideline, there was an old definition called HCAP that probably you remember from the ICU times as well, is that the healthcare-associated pneumonia that when our panel, the IDSA ATS panel, decides to evaluate the validity and the utility of this definition, we noticed that actually that definition really did not really help us to define which microorganisms were most common, and did not help us to define which antibiotics should be used. Actually, that definition itself was leading to a unnecessary use of antibiotics, especially in emergency rooms, because sometimes patients would be coming just from, let's say, a nursing home or a dialysis center, infusion center, and right away they would be labeled as HCAP and get very broad-spectrum antibiotics. We noticed that actually these patients did not need broad-spectrum antibiotics, and we decided to, after a very extensive systematic review, we decided to remove that from the guideline, and we actually we suggest the CAP guideline, the CAP panel members, to reevaluate that to see if it would be useful for them. And a couple of years later, the CAP guideline reevaluate that and decide that actually HCAP should not be an entity as well for community-acquired pneumonia. So the bottom line is HCAP is extinct, does not exist for either HAP or VAP or CAP, and this is really important because it's not really a reason to justify broad-spectrum antibiotics anymore, because these patients are not at higher risk than the general population for multi-drug resistant infections. So I think this is something important for us to clarify, Sergio.
Excellent, and I agree, very important. Why is it important to have these operating definitions, and how does it impact our empiric initial therapy?
Yeah, so this is, it's important because once we have this operational definitions, we can kind of direct the diagnostics and therapeutics in a much better way. For instance, if you're thinking about, let's say, community-acquired pneumonia, in the sense that the patient likely acquired the infection before coming to the hospital, your diagnostic focus is going to be mostly on microorganisms that live in the community. So you're going to be thinking about but strep pneumonia, you're going to be thinking about influenza, you're going to be thinking about different exposures where the patient could have been. So all these things, so you're going to have to really direct your bedside history and physical examination towards causes that were acquired before the patient comes to the hospital. Once the patient fulfill the definition of HAP or VAP, your history and your physical are going to be much more focused on the immediate sources of these infections that should be very close to you in the hospital setting, in the ICU or in the wards or in the hospital at work. So the point here is that we'll change your diagnostic and therapeutic approach, because you're going to have to really focus on the immediate sources of infection in somebody that has been in the hospital. So I'm glad you asked this question, Sergio, because sometimes it sounds like this is just semantics and, clinicians and scientists trying to just, have some fun with this variety of definitions. But this is real. These are really practical and important definitions that will help us to direct our approach to our patients in the ICU.
Excellent. And could you also talk a little bit about within community-acquired pneumonia, there's obviously a range of severity, and in the ICU, we see the most severe types of pneumonia, and there is an entity known as severe CAP, correct?
Mm-hmm.
How do you think about that as an ID expert in critical care?
So, Sergio, it's an evolving severe CAP or SCAP it's an evolving definition. I think that it is fair to say that if you look at the literature, you're going to see, a relatively diverse set of definitions. But I think it's fair to say that there are a few things that are quite common to most of the severe CAP definitions. So these are going to be patients that are going to be being admitted to the hospital with severe hypoxia. So they will be requiring either high flow, non-invasive ventilation quite fast as soon they get into the hospital. Sometimes they have to be transferred to the ICU because they're severely hypoxic despite non-invasive ventilation. These are the patients that usually I tend to think that you should really be way more immediate in terms of approaching them and defining the best management, because once they have this progressive hypoxia and being a little more specific, you're going to see, if either by O2 sats or if the patient is intubated by ABGs, you're going to see usually PDF ratios and PaO2, FiO2 ratios on the range of hundreds to hundreds. These are going to be the situation where, patients really are progressing relatively fast. And I think that's fair to say that this, to me, is going to be the most important part of the definition of severe CAP. And, we could add different things. We could add biomarkers, we could add like white count, we could add CRP and ProCal and all that stuff. But I think to me, nothing is going to replace the understanding that the patient really is getting dyspneic, hypoxic, and progressing quite fast. And I think that really, to me, is the hallmark of somebody that's developing severe CAP. And then we could add radiological findings, biomarker findings, but this is not going to change. The other thing that to me is really important, Sergio, is especially before a patient gets intubated, if the patient starts developing hypotension, that in that situation where now you're thinking that maybe the pneumonia is causing septic shock, it's quite severe. And even if the patient is not intubated, what's not that uncommon, if the patient has a good pulmonary physiology still without too many comorbidities, they can develop septic shock without still progressing to invasive mechanical ventilation. So it is an important sign of severe infection that cannot be missed as well, even if the patient is not intubated. So I would say still very practical, very old-fashioned. Progressing severe hypoxia, progressive severe hypotension are going to be the big drivers for me to define that this patient has severe CAP. And I don't think this is going to change in a short term, Sergio.
Perfect. Let's talk about the initial management of ICU pneumonia. And maybe if you could just give us an overview of what an appropriate initial diagnostic workup would be, and then we can dive into a little bit more about therapy.
Yes. So, Sergio, diagnostic things are evolving in a very positive way. I mean, the bottom line is the history and the physical are going to be very, very important. Basic things, let's say, patients that have, let's say, if the patient has a history of splenectomy, has a history of alcohol drug use, these patients are going to be more prone to encapsulated microorganisms like streptococcal pneumonia. So these are, situations where you don't want to miss, because strep pneumonia is a deadly bug. It can be really life-threatening and severe. And so if the patient has, risk factors or certain infections, we're going to talk a little more about this when we talk about non-responding pneumonia as well. But this part of the history is really important. And as an ICU doc, as an ID doc, getting good history is going to be, for CAP specifically, is going to give you a very, very, very good advantage in terms of refining the best therapy that you're going to use, the empiric therapy, because at that time, likely you're not going to have the diagnosis. Probably it's going to take another day or two until you have the diagnosis. And if you're lucky, because the reality is when you look into sputum cultures, is going, the proportion of patients you're going to have a positive sputum culture is going to be probably in the range of 20-30% anyway. So the reality is, still in most places of the planet today, close to 2/3 of these patients, you're not going to have a specific etiologic microorganism. So you have to deal with your best empirical therapy, your best history, your best physical examination. This is not going to change in a short term. But the good news, Serge, is that we have we have the labs. We still have like basic labs, white count, a number of bands, number of neutrophils. If the patient, let's say, if the patient is neutropenic from some chemotherapy or cancer, patient is immunocompromised, this is going to help to understand what kind of risks the patient has. If the patient has a very severe leukocytosis, is going to give, with Bandem, is going to give a sense that this is a very acute and progressive infection. Biomarkers like C-reactive protein procalcitonin can be complementary to try to understand the extent of the disease, the extent of the inflammation towards the disease, but they alone will not really give the whole picture. Remember, all these biomarkers will be complementary information to you, so they can help in diagnose, for instance, but one thing that's very important, especially nowadays, Sergio, I want to emphasize this, especially when it comes to diagnosis. It's not uncommon for me to see patients coming with acute pneumonia and actually quite ill, still without too much leukocytosis or normal procal or normal CRP. Because remember, it takes a bit sometimes, especially if the patient has some comorbidities, it takes sometimes a day or two for us to see some of these inflammatory markers to go up. And so don't mislead yourself with these negative biomarkers, because I see tons of patients with severe pneumonia with no leukocytosis and normal procal and normal CRP when they're admitted to the hospital. And that should not detract you from actually following up your diagnosis and treating these patients aggressively, because these biomarkers, they are not reliable, especially in the very beginning of the disease. They are not reliable in terms of ruling in these infections. So this is something that I think it's very important for us to remember. The other thing I want to mention, Sergio, is that we're still learning, but it's a growing process in which we have if you're able to get the sputum, we have now these PCR panels. We have several platforms with PCR, something that we didn't have until just a few years ago. So once we get the sputum, we not only are able to do gram stains that can be quite useful in cultures, but we can do a PCR. So we have the PCR of the sputum, we have the PCR of the nasopharyngeal area as well. So we can actually screen close to 20 different microorganisms, both in the nasal swab and in the pneumonia panel. So this is, to me, has been quite useful, because we can potentially have the potential etiology of CAP, in the first, few hours of the patient admission. So it's kind of almost shocking thinking about how I was, I practiced my medical school so many years ago, in which we didn't have any of this. So I think that these things are evolving. These things are changing. The data is still is evolving, but I think that all these PCR techniques they'll become a little more a part of a routine. And again, none of them will be alone giving you the final diagnosis of anything, but they will be complementary to your. You could have a positive swab for something in somebody that's colonized with a virus or colonized with a bacteria, but if you don't put together that PCR panel with the clinical picture of the patient, you may end up not helping a patient or even harming. So the point is, all these sophisticated technologies I think they can be quite useful, but again, in the context of the clinical assessment. So I would say that diagnostic-wise, that's going to be pretty much and sure, we don't want to, forget the radiology. The radiology is going to be key here because, a lot of times our physical examination, especially of the lungs, is quite limited, and the chest X-rays will be usually the first kind of approach, simple, fast, and the chest X-rays can show clearly an extensive pneumonia, but also chest X-rays can potentially not be that useful in the beginning of the picture, and if you still have a high, what you call pretest probability, if you have a high suspicion of pneumonia, a chest X-ray alone, it will not rule out the pneumonia. I think it's important for you to think that you have all the rights to move forward and think about a CT scan or maybe a lung ultrasound POCUS that can give you also some more information. But it's never get detracted by a normal chest X-ray, because a normal chest X-ray alone is not sufficient to rule out the pneumonia if you have a high clinical pretest probability. So it can be very useful if it's positive, and maybe not so useful if it's negative. So once you put together the history, the clinical, the laboratory, and the radiology factors all together, then that's going to give you a much better sense of how to approach. And we're going to talk a little more about the empiric antibiotic. You want me to talk about the empiric antibiotics a little bit now, Sergio, or
yes,
later?
In a second. I wanted to ask you, and we'll talk about VAP and other situations a bit later. But my question, for community-acquired pneumonia in the ICU, when do you push for a little bit more aggressive diagnostics, like maybe a BAL?
Yeah, so the BAL, Sergio, is usually I'm not overly excited about doing a BAL right in the beginning, especially because these patients are quite ill. If they're not, if they're intubated, it's a no-brainer. If they're intubated, I would get a trach aspirate right away. As soon as you get the tube in, we're gonna get a trach aspirate, because the reality is the trach aspirate can be incredibly informative at that point, and it probably is going to be as informative as BAL at that point. But usually, I tend to be I tend to be a little more aggressive in terms of looking for a BAL or a mini BAL when the patient is not responding to the initial therapy. So I don't go first as with a bronchoscope one before intubation, because likely these patients are quite vulnerable and very ill. Then if you're going to do a bronchoscopy, likely the patient will remain intubated. And if they're intubated, I'll get a trach aspirate, as I do with probably most of the pneumonias in ICU. But if the patient is not responding to my initial approach, that's going to be the way that I'm going to think about moving towards a more invasive diagnostic tool. But bronchoscopy is not really part of my initial approach, because it is, at least the evidence that we have, it is something that's not going to change your management in that first 24, 48 hours.
Excellent. Now I think we could talk about empiric antibiotic therapy and how you would approach that.
So, Sergio, it's sure that it's going to vary a little bit about where you live, because some of us live in geographic areas with more resistant organisms or less. For instance, if you live in South Korea or Taiwan, they have a very high incidence of resistant strep pneumonia. So they will have to be, they have to approach a little bit different how they treat strep pneumonia there compared to how we treat strep pneumonia here in Nebraska and the States. So the point is, you have to know a little bit of your local kind of community, and then kind of what kind of infections they have in your geographic area. This is really important. But that being said, I would say, Sergio, that in a vast majority of the planet, once you have a patient with CAP being admitted to your ICU, you're going to start a beta-lactam, either ceftriaxone or cefotaxime, ceftaroline, and or ipsubactam, some the kind of the usual antibiotics that are going to be quite useful in the situation, in combination with the macrolide, either azithromycin or clarithromycin. That's pretty much, most of the guidelines are quite consistent on this. So you wanna kind of approach both the beta-lactam and macrolides, because you're gonna catch most of the bacterial, both the typical and atypicals like Legionella, Mycoplasma, and so forth. So this is reasonably, I would say it's a reasonable approach that I do here in Omaha, and most of the guidelines are quite consistent. What gets a little tricky is sometimes when patients cannot receive some of these drugs, and that really adds a little layer of complexity. But I would say, it's fair to say we don't need to get into the kind of the details of the types of allergy and so forth, but I would say that in general, beta-lactams and macrolides are going to be the biggest regimen for most of the ICUs in the planet. Tetracyclines like doxycycline can be quite useful as well if you cannot use macrolides, and also tetracyclines can potentially even have better activity against some of the Mycoplasma. Depends where you live, but they can be quite useful as well. So I think doxycycline is a drug that has not been much studied in the ICU, but I have a feeling that we're going to see more use of this drug in the future in the ICU because of this potential, if we have a higher prevalence of some of these atypical organisms like Mycoplasma, potentially is going to be useful. So I would say that's a good general approach for community-acquired pneumonia in general, Sergio.
When would you consider MRSA coverage in a community-acquired pneumonia?
Well, it's a very good question, Sergio. I might say, generally speaking, we don't. But that being said, we have to be sensible to the fact that some of our patients maybe have had exposure to MRSA by different reasons. Either the patient has some kind of comorbidity, some kind of underlying condition that leads to if the patient had a history of let's say if the patient comes to the hospital, the patient already had MRSA infection in the past, either pneumonia or endocarditis or something, or the patient had a history of substance drug use or something that put the patient at very high risk for MRSA. I think it's quite reasonable to approach empirically. But again, this is going to be really important to know if the patient had a significant history, a risk for MRSA. I mean, overall, in general, if I don't have any kind of risk factors for MRSA, is not going to be a bug that normally will cover for CAP.
Andre, you mentioned a little bit about understanding your local kind of flora according to where you live. Could you share with us your thoughts on the antibiogram of the hospital? Something that obviously our ID colleagues are very well aware, but I believe that sometimes the intensivists forget.
Yeah, I'm so glad you asked that, Sergio. I mean, we in our 2016 IDSA ATS HAP-VAP guideline, we really, it was the first time ever that the guideline came up with the recommendation of local antibiogram. Actually, we recommended both to have an antibiogram in the ICU and in the wards in different units, separately, ideally, from the hospital, because we at that time the whole panel agreed that that would be the best tool that we could have in the ICU to manage empiric pneumonia, both both HAP and VAP, and it really, and we since then we've had many studies already been published showing the utility of having this antibiogram. So if whoever's listening to us today, surgeries, works in the ICU, with a lot of pneumonia, I definitely would strongly recommend you to talk to your infectious disease team, your infection control, microbiology, and ask how can you in the ICU can be provided as we are here, for instance, at the University of Nebraska. Every 6 months, we have an update of our units and wards in terms of what bugs have been cultured and have been being positive here in the micro lab. So we have this list of percentage and kind of prevalence that we have in a hospital. It's incredibly useful because we can be way more precise in terms of choosing the antibiotics. We can be way more precise in terms of getting them right and managing our patients in a much more precise way. So I think we can do better individualized, personalized medicine. And I think we can get the infection cleared much faster because, if you start with the right antibiotics, you're gonna definitely speed up the recovery process of your patient with severe pneumonia. So local antibiograms, ideally ICU antibiograms, wards antibiograms are incredibly useful, and they should be standard of practice in every single hospital of this planet. And that's the best way because the truth, Serge, is that most of us in the ICU will not have the diagnosis immediately. We're going to have to start an empirical approach. And in order for the empirical approach to really do well and be successful, you have to know what is your flora in your ICU to get antibiotics right. So this is something that I'm going to emphasize forever and ever because it is really, really important.
Perfect. Before we move on to VAP, over the last couple of years, there's been a lot of discussion about the role of corticosteroids in septic shock, but also some emerging trials in pneumonia with COVID. We went through this. From your perspective, for severe community-acquired pneumonia, is there a role for corticosteroids, and what is it?
Yeah. So, Serge, it's a difficult question because nobody knows yet, even though the studies are quite contradicting. And we had the Cape Cod and had the Escape, two randomized trials recently done. One fully negative, one fully positive in the sickest patients. But, basically, why I'm telling that, I'll give you an example. In Cape Cod, in the French study, these are the patients with the most severe CAP were the patients that had, showed some benefit from steroids. But the issue here is that they had to screen about 6,000 ICU patients in order to end up with 800. So why that's a concern to me is because, most of the patients that they screened, they could not really put in the study, in the sense that brings the generalizability of these results to my ICU quite questionable. You know what I'm saying? The problem is when you end up with a very small selected patient population, it's very hard to know if that patient population can be translatable to my patient population in my ICU in Omaha. And that's the concern I have when we have studies like this, in the sense that they are so strict in their inclusion criteria that you cannot extrapolate that easy. So that's the concern I have. The other concern I have is that another randomized trial, the Escape, that was also large and well done, didn't show any benefit. So I think still the validate is out. Still, we don't know for sure. But I think it's reasonable to say, Sergio, that when you look at Cape Cod, the patients that likely had more benefits were the ones that had a PDF ratio less than 150. So these are incredibly ill patients, and patients that had a CRP greater than 15, and they were not intubated yet. So my take from Cape Cod trial is that if the patient has appropriate antibiotics, that you're giving at least your best empirical approach. The patient has a PDF ratio less than 150, a CRP greater than 15, not intubated. It's a patient that I give consideration to give steroids in my ICU. But other than that, and these are incredibly rare patients, very, very rare patients. Most patients are not that ill. And to be honest with you, a lot of these patients are going to be already in septic shock, in which septic shock, and following the Surviving Sepsis campaign, at that point, it's not unusual that they're already going to be in steroids for refractory septic shock. So, kind of that wraps up a little bit my my take on this. Is nobody knows for sure if steroids are beneficial in this instance. But if they are beneficial, they're going to be beneficial in the most ill patients still. Very importantly, that are receiving the most appropriate antibiotics. Because if they are not receiving the appropriate antibiotics, you can give how much steroids you're going to give. The patient is not going to do well.
Yeah, I think that's important, right? That's a determinant of good outcomes is the early initiation of antibiotics that cover the pathogen that's causing the problem.
Absolutely. Absolutely.
Let's dive into ventilator-associated pneumonia, or VAP, and maybe start with a overview of the pathophysiology and why do patients on ventilators develop these pneumonias?
Yeah. So, Sergio, the unfortunate when when you have a endotracheal tube, we block a lot of the defense mechanisms that we have normally, all the seed and everything else, all the secretions that normally come up that we don't, we don't even feel it. We are talking now. We have, our lungs are, being self-clean 24/7, and we, basically we stop all these defense mechanisms of the upper airways when you have ET tube, and that's really makes the patients more vulnerable to have infections because you lose a huge defense mechanism. On top of that, I mean, and we could talk for a little longer about this, but on top of that, some of these bugs will adhere to the tube, will potentially, lead to all kinds of different colonizations, biofilms, and different things. The same way we see with, with endovenous catheters as well. So there are different things that can potentially become part of the ET tube, and that potentially can contribute to as well. But I would say, in general, Sergio, the way we learned throughout the last 20 years or so, the majority of these hospital-acquired pneumonias, ventilator-associated pneumonias, are going to be by microaspiration, meaning that's going to be a very, usually it's not going to be a very large amount. It's going to be a small amount of bugs that are going to be migrating from the upper airways to the lower airways, and then you say, well, if this is the case, then why? Why we see a different bugs, right? Why we don't see the usual community acquired bugs? And this is a good question. The reason why is because once you're in a hospital, your mouth flora, your upper airway flora changes. The longer you stay in a hospital, the more your microbiome, your normal flora in your mouth is going to change, and your usual gram-positives, anaerobes, bugs that you have in the mouth are going to be replaced by a lot of gram-negatives. And that includes Pseudomonas, Clab, E. coli, all this stuff. So it's basically, it's kind of the environmental change, that kind of critical illness change. And so now you get, your flora changes. And the longer you stay in a hospital, the more change you're going to have. There are some very good studies done in Germany about 10, 15 years ago showing the change when they culture this patient on a regular basis when they're in the ICU on their upper flora. So the idea here is that you will be colonized with a different flora, and this different flora will be the gram-negatives that usually are going to be associated with nosocomial pneumonia. So that is, in short, the kind of the pathology and the physiopathology of these patients. And remember, for every day that you remain intubated, you increase your probability of developing nosocomial infections by something in the range of 5 to 10%. So it goes up pretty fast. So it's just, that's why I think one of the biggest jobs we have in the ICU is to be really, to be very precise about extubating patients when they don't need any more to make an ventilation, because the longer they stay in the ET tube, the higher the probability of developing a nosocomial infection.
What are the diagnostic criteria, Andre, for VAP?
So, the VAP will be a little bit changed in a sense compared to CAP, because, the vast majority of these patients will be intubated. So the way that we analyzed this whole evidence in the 2016 HFF guideline was to look for potential differences between sputum and trach aspirate and BAL, mini BAL, and so we in quantitative cultures, qualitative cultures, we look into all the possibilities. And once the panel really did this very extensive systematic review, Sergio, we came up with the conclusion that actually there is no outcome change. Once you make the diagnosis of VAP, there is no outcome change differences between collecting a trach aspirate and collecting a BAL or a mini BAL. So basically, at that moment of diagnostics, whatever test you do is not going to change the outcome. So that's why we made the recommendation of trach aspirate, because it's much less invasive than going directly for bronchoscopies in these patients. And the trach aspirate, again, very important, as we recommended the guideline. The trach aspirate has to have quality, has to have enough white cells for the microlab to process, usually more than 20, 30 white cells, very little epithelial cells, less than 10 epithelial cells. That means this is not a bad respiratory sample. And with that good sample, you can do either a semi-quantitative or quantitative culture, and all of them are going to pretty much be as useful in terms of outcomes compared to the studies that used bronchoscopies and invasive BAL collection. So that's kind of still remains there's no data, no evidence that changed that recommendation from 2016. We'll talk a little more. We'll talk back about bronchoscopies once we have these patients, the proportion of patients that do not respond to initial therapy. But initial therapy, initial diagnosis is going to be trach aspirate pretty much in any place. You don't need any special technique. Just get a good sample, bring to the lab. And ideally, you just can do either a semi-quantitative or quantitative culture. You do a gram stain, and that's going to be probably one of your best tools to narrow down and be more precise with your antibiotic approach. Now, very important, Sergio, I want to bring this up too, is that the history and the physical are going to be really critical for the therapeutic approach. I don't know if you want me to just start talking about the therapeutic approach at this point.
Sure. Why don't we talk a little bit about therapeutic approach for VAP and how you would think about this?
So one thing that I wanna bring to everyone, Sergio, is that I'm very proud to tell you that the way that we kind of put this together in the 2016 guideline was something that really changed the practice in many places in the world, and I think it's really for better, because there were three factors that we put together in order to choose the empirical treatment. One is epidemiologic, correct? So if the patient now has VAP and it is a patient with a history of IV antibiotics in the last 90 days, 33 months, or if the patient has been hospitalized for more than 5 days, that is a epidemiological feature to tell that this patient has a risk of developing a MDR infection. So this is important, but this is a patient that has been exposed to antibiotics and has been in the hospital for a long time. Factor number two, local antibiogram. As we talked before, local antibiogram is going to be key for you to know if your patient now in the ICU is at risk for multi-drug resistant infection or not. So knowing your flora is going to give you that kind of perspective. And we have very specific recommendation and guideline about what flora and what proportion of flora should you be concerned about using more expensive and broad spectrum antibiotics. Third factor, Sergio, that is very clinical. If you're suspecting the patient is developing VAP, and the third factor is going to be, and the patient has either septic shock or ARDS or acute or need for acute renal replacement therapy. These three factors, they will indicate that this patient may be at risk for a multi-drug resistant infection. So these are measures of disease severity that we emphasize in the guideline, that you don't have too much room to just kind of, let me start with something a little bit more mild, and let's see what's going to happen. And these patients are incredibly ill. If they already have septic shock, ERDS, or AKI as part of the organ failure secondary to the pneumonia. It is this patient has a very high mortality. You don't have too much time to play around with antibiotics, so we tend to be way more aggressive, and that's how we put this together, guys. So basically, three factors: epidemiology, local antibiogram, and disease severity. These are going to be the biggest factors to decide how broad you're going to be in your antibiotic management. And so, that being said, Sergio, the recommendation is going to be mostly for, in this situation with these three factors, likely you're going to have to cover etiologies like Pseudomonas and non-enteric. So, you can use either beta-lactams, like piptazo, ceftazidime, cefepime. We don't recommend carbapenems right away, but if that's all you have, carbapenems, imipenem, meropenem should be plenty, but we tend to reserve them after we try cephalosporins or penicillins. But basically, coverage for Pseudomonas is going to be probably more important in this situation if you have a local antibiogram and disease severity or epidemiology. For MRSA infections, a cover for MRSA is going to depend on your local antibiogram. And it's interesting, Sergio, when we talk about this, and I've traveled the world in all continents talking about this, and I always see some ICU colleagues tell me, well, in my ICU, we see maybe one MRSA pneumonia a year or two. We don't even start vancomycin in the vast majority of the patients. So again, it's the antibiogram, and I've been in places where they cannot just stop counting how many MRSAs pneumonia they had, and they don't have a choice other than starting vancomycin when they have a suspicion of VAP. So I think the point here is knowing your local antibiogram, knowing your local flora in your hospital and your ICU is going to be key. And the other thing that we recommend in the guideline, it was a preliminary recommendation, but now we have way more data after 2016, Sergio, is that if you have ways to screen the patients right away, you can do a nasal PCR or a nasal culture. For MRSA specifically, if the PCR is negative for MRSA, there is a substantial amount of evidence showing that you're allowed to go ahead and not start or stop the anti-staphylococcus coverage, because it is very unlikely somebody's going to develop a MRSA VAP with a screening test negative. And again, that brings to mind, Sergio, what we talked before, the importance of understanding what you have in your upper respiratory flora. And if you don't have MRSA there, it's unlikely that you're going to have in a lower flora. So that's kind of one thing that we do in our hospital as well. We quickly screen to define if you're going to need or not the anti-staphylococcal coverage. And that's great because, if it is negative, you minimize unnecessary drugs, you minimize toxicity of the antibiotics, and it's a win-win situation.
Is there a role for a double gram-negative coverage?
Great question, Sergio. So what we recommend in the guideline, and it still is the same recommendation up to today, is that if you have a high proportion of resistant Pseudomonas in your ICU, we definitely recommend to go ahead and double coverage until what culture you're going to get from the trach aspirate. If you have a very, very low prevalence of Pseudomonas resistance to beta-lactams in your ICU, we do not recommend double coverage. So again, coming back to the original questions, if you know your local antibiogram, if you don't have an antibiogram, you don't have a local antibiogram, you have somebody that's that ill, severely ill, especially with that disease severity, we suggest to doubling coverage until we have the cultures back. But remember, the double coverage, the same story for septic shock. The double coverage is only recommended when you do not know what you're dealing with and you believe that the patient is in a life-threatening situation. It's totally reasonable. There's nothing wrong with this. But it's not to increase the speed of clearance of the infection. It's not to kill more bugs. We do not achieve that, correct? So the point is very important for people to realize that giving 2, giving 3, giving 4 antibiotics, we were not going to speed the clearance of the infection. That's not the goal. The goal here is that if you're wrong in your empirical treatment and you're giving one drug, you're going to be really wrong because the patient is going to get nothing, correct? So the advantage here of having double coverage is to make sure that you as a clinician is not making a mistake of giving monotherapy that is not going to help the patient, because if you're giving a monotherapy that is wrong and now you get a culture 2 days, but 2 days later, 3 days later, your chance of helping this patient is going to be minimized. It's going to be much smaller because now you did not treat this patient for 2 or 3 days. So that's why we emphasize that double coverage is for situations of very high risk for multi-drug resistance, very ill patients, and your goal is to make sure that you have at least one of these antibiotics working. Once you have the culture back, and it happens all the time, Sergio, once you have that Pseudomonas back, multi-sensitive, let's say, in next day or two from the sputum culture, immediately I de-escalate and I stop the second antibiotics because you will not provide any further benefit continuing the second therapy. So this is very important to emphasize, Sergio.
And you mentioned de-escalation, and when you have the culture, it should be easy, although I do believe that sometimes clinicians still have a hard time to de-escalate in very sick and critically ill patients. But if you have a culture, you have the roadmap to de-escalate. How do you approach de-escalation when the cultures are negative?
Right. So when the cultures are negative, and it's always more challenging, Sergio. I'm glad you brought this question because now you're a little bit in the dark, So your de-escalation is going to really be dependent on the clinical progression and improvement of the patient. If the patient, I'll give an example. If the patient is doing fairly well, everything is doing well, the patient fever is down, hypoxia is improving, the patient now is getting close to get extubated. I'm very fast about escalating because I can see that the patient is moving so well along and is responding so well to antibiotics and the supportive care. So the clinical picture is going to be my gauge to de-escalate. And again, you have to read the patient. You have to be watching the patient very closely, 24/7. And that's going to be my biggest, and believe me, if you have a patient with VAP, that is not improving in about 3 to 4 days, something's wrong. You're missing something. We're going to talk a little more about this, but it's not because the patient likely is needing another 5-10 days of antibiotics. You're missing something. You're missing a bug. You're missing something on infections. But the point is, do not get desperate and adding and escalating without looking for why the patient is not responding. But if the patient is responding, Surgeon, in a nutshell, if the patient is responding to your initial empirical therapy, I am very fast about escalating because there is no reasons to keep giving antibiotics when the patient doesn't need anymore. Once the patient is getting to that point of getting extubated, getting out of the ICU, non-invasive pressors, the patient, now the patient's own immune system is pretty much in charge of everything, and it is time for you to de-escalate antibiotics. Now all you're giving is side effects. You're not giving too much benefit. So it is something that you're going to have to do individualized in each patient, and you're going to have to follow the clinical picture. It's a little more complex because we don't have the cultures, but I think it's doable, and I do that all the time.
How do you think of duration of antibiotics for severe CAP and for VAP?
So it's for severe CAP, it's not going to change much. I tend to use kind of the 5-day mark as a general kind of just as a general approach. It depends again, if the patient is improving fast, it's going to be probably 4 or 5 days. If the patient is not improving fast, it's going to be maybe a little more, 5, 6, 7 days. But it's going to be, each patient is going to be different. But I would say on average, something in the range of 5 to 7 days is going to be my upper limit for a cap. If the patient's not improving, I have to think that I'm missing something. Something is not doing right, because any patient that has a true community-acquired pneumonia and is receiving the proper antibiotics, it should definitely be pretty much resolved by that kind of 5-7 days course. When it comes to VAP, Sergio, the way that we reviewed the data on the 2000 and 2016 guideline was that clearly most of the evidence, RCTs, observational studies showing that 7 days should suffice for the vast majority of the patients. Again, individualized, we are not machines. We can treat a patient for 6 days, for 5 days, for 8 days, for 9 days, but on average, it's going to be 7 days. And if the patient is not improving within 7 days, you better revisit your diagnosis, your history, what's going on, and because there's something that potentially you could be missing. So the point is simply prolonging antibiotics most of the times means prolonging the lack of a diagnosis and potentially missing what's happening to the patient. So that's why it's not simply say, these are infectious disease dogs that just want to save antibiotics. No. Listen, I don't want you to miss the boat and what actually is happening to your patient in the ICU. And that's why it's really important for us to realize that prolonging antibiotics is not the solution. The solution is using the right antibiotics for the right time, but prolongation is not going to do anything. So there's no reasons today to give more than on average, something range of 7 days for the vast majority of patients with ventilator-associated pneumonia, Sergio.
Perfect. And this is a good time to introduce the topic of non-resolving pneumonia, something you wrote about beautifully recently in a narrative review with other colleagues. How and when do you define a non-responder?
So, Sergio, this is a gap in the literature, and that's why we wrote this paper for ICM. So there's a huge gap. There's not a lot there that we can really be very precise about what it is. But that's why we decided to just take a nice group of people that really are very experienced on the theme of pneumonia, very experienced in seeing patients with pneumonia. These are a combination of intensivists and pulmonary docs and ID docs. It's a nice combination of different specialties, and we just try to come up with something that could be didactic and helpful to clinicians at the bedside, especially in clinicians that see patients with severe pneumonia. So, Sergio, the way that we approached was that usually patients that are not responding in the 48, 72 hours is how we define that you should be kind of rethinking about what you're doing. Because the vast majority of patients, either CAP or VAP, when you get into that kind of 2 to 3 day mark, you should be seeing things in the right direction. When you see things in the wrong direction, what I mean about wrong direction, correct? So basically, fever is not coming down, white count is not coming down, biomarkers like CRP or ProCal are not coming down or going up, and level of hypoxia, PDF ratio, things are not really moving in any better situation in 48, 72 hours. So when you get this kind of combination of, not improving clinically, not improving laboratory, radiology is a little more complicated because radiology is not going to improve that fast. So it's unlikely that even if you did X-rays, every few hours, it's unlikely would help you because X-rays don't change that much unless there's some kind of complication. But the clinical picture, the laboratory picture, and also microbiology is not going to help you too much because, getting another sputum or doing another swab is not going to help if you already have the etiology or you already did the diagnostics. So the bottom line is going to be your clinical, and in your laboratory is going to give you a sense of, what's going on, why this patient is not moving in the right direction. And usually the way we put in this paper is that, between 48 and 72 hours should be the critical time for you to see the change. Now, very important, Sergio, is that the non-responding rate varies very much by the etiology. So patients with CAP are going to have usually a prevalence of something in the range of 15 to 25, 30% of non-responding rate, while patients with HAP and VAP are going to be about 30, 40%. So why this is important is because the non-responding rate is going to be more prevalent in the hospital-acquired pneumonia and ventilator-associated pneumonia because these are sicker patients with a lot of other comorbidities, and that's why we see this. Now, delving into the non-responding pneumonia, Sergio, I think that's also very important as a clinician. I practice that every day because this is really important. Is you have to realize that there are patients that maybe will have a delayed recovery. And so, for instance, patients with advanced age, patients with alcohol use disorder, patients with COPD, or heavy smoking history, patients with heart failure, chronic heart failure, patients with pulmonary edema, diabetes, immune suppression, solid organ transplant patients, cancer patients. So you have to put in perspective as some patients likely will take a little longer to respond compared to others. So if you get somebody that is 85 years old with history of diabetes, hypertension, heart failure, that pneumonia is going to take longer to resolve than somebody that is 35 years old without comorbidities coming to the ICU with a community-acquired strep pneumonia. So this is even put in perspective always the host, the patient, that's very important. So that kind of gives you a sense of the speed of recovery. The other thing that's very important, Sergio, is the disease severity, correct? If somebody comes with a multilobar pneumonia, very extensive process, highly hypoxic, even if the patient does not get intubated, it's very likely that this patient will take a little longer to have a delayed recovery, a little longer to respond. So, put in perspective compared to somebody that comes with one lobe infection, require a nasal cannula of like 3 liters, comfortably laying down in bed. So they're two different patients, correct? Even though you can have both patients with the same etiology, the same Haemophilus influenza, the same strep pneumonia, if one has 2 liters of oxygen laying down in bed, the other one is in 50% high flow with 50 liters, that the recovery process is going to be different, correct? Because you're starting to see the patients in a different timing, different part of the natural history of the disease. The third factor that is going to be very important to define non-responding pneumonia, Sergio, is the care that we provide in the ICU. 3 things are going to be important in the care we provide to the ICU. One is going to be the resuscitation support, correct? If you're not giving proper amount of fluids, if you're not giving proper amount of oxygenation to these patients, supportive care, correct? So all these things, or pressors, whatever the patient needs. So if the patient is being under-resuscitated, likely the patient is going to have a delayed recovery. So that could be a reason for not responding. Related to care, antibiotics. This is part of my expertise. Choosing the right antibiotics is the first step, correct? So looking for your local antibiogram, everything else, but also very important, Sergio, is knowing that the antibiotics that you're giving are in the proper dose to penetrate in the lung parenchyma. A lot of times people forget that, they look at these little booklets with, kind of standard dose of antibiotics. And remember, you have somebody with sepsis, with septic shock, with the VAP. These patients have a very large volume of distribution. These patients will need high dose of antibiotics to not only because they have a very large volume of distribution, but also they have to penetrate in the lung parenchyma. So be careful, sit with your pharmacist, and look into how to really be, aggressive in terms of giving the proper dose of antibiotics to this patient. This is really, really important because once you underdose, even if you give the right antibiotic, if you underdose these patients, likely they're going to have a delayed recovery and they're going to look like non-responding. Yeah. The third factor I want to mention is source control, Sergio. So if the patient maybe is not responding because the patient has empyema, has a large pleural effusion, or lung abscess, or necrotizing pneumonia. So these are things that potentially, even if you're given the right antibiotic, even if you're providing the right resuscitation measures, if the patient has a lack of source control from the same infection, that's going to be another reason for delayed recovery and potentially being labeled as unresponding pneumonia. So these are the things that I bring to you that are going to be important. It's going to be pre-existing factors, comorbidities, disease severity presentation, and care related in terms of resuscitation, antibiotics, and source control. These are going to be the things that are going to help you to define who is and who is not responding to the pneumonia treatment, Sergio.
Once you define as a non-responsive patient to appropriate treatment, like you clarified, What are the causes or the differential diagnosis that we should consider?
So I would say that there are a couple of things that are going to be very important. So I think that's the two things that you want to think in your mind when you're in this situation, Sergio, is the following. Um, am I missing something, or what could I be missing? So I think the two big misses, going to be: is my missing infectious disease related, or is my missing non-infectious disease related? Correct. So I think these are going to be the two big buckets that are going to be, you're going to be thinking when in the situation. So what things could I be missing that are infectious related? So one is if you're, given the proper antibiotics and everything else, but now turns out that the patient, has a local exposure to something else that you didn't know. Let's say the patient is a farmer and was working with delivering calves, and maybe the patient has Q fever, Coxiella pneumonia. So these are things that I want you to think about. Okay, even though everything you're doing is, per the book, everything is well, but the patient is not doing well, maybe the history is going to help you to define that there is another infection that you missed when the patient was diagnosed based on local exposure. The other one is travel exposure, correct? So let's say the patient is, the patient was traveling to some endemic area of, like, let's say, tuberculosis, South Africa, South Brazil, India, places that potentially a patient acquired tuberculosis, traveled back, is back in your country for a few weeks or a few months, and now is developing pneumonia. So looks like a bacterial pneumonia, but it could be definitely tuberculosis. So travel exposure is going to be important. So revisiting your history is going to be very important. And never forget that one thing that is going to help you to find potential infection reasons for non-responding is pre-existing disease and comorbidities. They are incredibly important. I'll give you an example. If the patient has a history of cystic fibrosis, or if the patient has a history of COPD, a lot of times you can already have a very good understanding of what kind of infections this patient, especially CF patients, they're going to tell exactly which infections they had in the past, which infections they're colonized. So they can actually give you a picture that's going to be much more precise than almost anything else, because they know their history. Patients that are solid organ transplant patients with cancer and chemotherapy, patients that have a history of treatment for HIV, in which the level of the HIV care is going to help. If the patient has very low CD4, high CD4, low CD4 is going to be more prone to, let's say, pneumocystis uravaci. So all these things, Sergio, is going to be revisiting the history. And what I always say, if your patient is not responding to your management in the ICU in the first, a couple of days, 3 days, you have to go back, revisit the history, because that's going to give you a better understanding if the non-responding is related to the fact that you have another infection, not unexpected infection or not. If you go through all this very, very thorough, revisitation of the patient's history and physical, and still you don't pinpoint anything else, at that moment you have to start thinking about non-infectious etiologies. And there are a large number of non-infectious etiologies that mimic pneumonia in the ICU, either CAP or VAP. And just to give you a little bit of approximation of the rate of this, Sergio, if you look at most of the studies, you're going to see that in general, 15 to 20% of the patients admitted to ICU with pneumonia don't have pneumonia, don't have infectious pneumonia, don't have any infectious etiology. So, think about close to 1 in 5 patients that you believe that have, infectious process-causing pneumonia, they don't. And these are the patients that are not going to respond to your antibiotic therapy or supportive care. They're not going to do well. And these are going to be the ones that are going to be, in the non-responding pneumonia group. And one of the things that I always say that is going to be quite fast, easy, and available in most places is just a very plain old CT scan of the chest. You don't need even contrast, even just a very plain CT scan of the chest, because right there, you can potentially diagnose a pulmonary embolism, you can diagnose a pulmonary edema, you can diagnose neoplasm, some types of cancer, metastatic cancer, or lung carcinoma. So a lot of things, a chest CT scan alone can help you to look for non-infectious cause. Also, very important, sometimes by image and by the history, you can diagnose eosinophilic pneumonia, you can diagnose hypersensitivity pneumonia, drug-induced pneumonia, vasculitis. So if let's say if you have a suspicion that this could be, sometimes even by CT scan, you suspicion this could be blood, could be some kind of alveolar hemorrhage, you tend to see a little more this rheumatological disease, antiphospholipid disease, and so forth. Then you're going to be looking for ANCA and some of the vasculitis workup. And vasculitis workup in SU has to be something that you never forget, because this could be quite dangerous and life-threatening to our patients as well. So look for, again, rheumatological disease, autoimmune disease, cancer, allergy, drug-induced disease. All these things can mimic pneumonia. And that has to be seen, Sergio, has to be evaluated in parallel with all the other infectious process. So basically, you want to really be very, very extensive in your thinking about infections and non-infectious process that could lead to non-responding pneumonia. And on that way, you're going to pinpoint what is the reason for the non-responding pneumonia and approach that in a much more personalized way.
You mentioned earlier, Andre, that the answer in terms of therapeutic conduct for these patients is not to keep throwing antibiotics in terms of having people on prolonged courses or adding a broader spectrum antibiotics or more powerful antibiotics, but to really rethink what may be the cause. Any other comments you can make on treatment of those patients with non-responding pneumonia?
No, I think that the key point here, Sergio, is that if you do not find the specific reason for why the patient is not responding, you're not gonna benefit your patient. You're not gonna help your patient. So this is not a time for you to start kind of throwing all kinds of different things that you don't know what's happening. Basically, not knowing what's happening is what's gonna harm this patient. So your biggest job is to really find the reason for why the patient not responding. Otherwise, you're not gonna have the proper treatment.
And to summarize, the way I see this based on what you share with us is that first fork is infectious versus non-infectious.
Yes.
If we think it's non-infectious, then obviously the cause ultimately will dictate the appropriate treatment. So we have to figure it out. And if it's infectious, the three possibilities. The pathogen that is causing the problem is not being covered appropriately. B, I have the appropriate antibiotics, but they're not reaching the lung because I'm underdosing or there's other bioavailability or issues, which obviously we can probably solve with our clinical pharmacist colleagues. Or number three, I have the appropriate antibiotic for the appropriate bug, but there's a source control problem that I have not identified, whether I have an empyema or a septic joint now or something else going on. Would that be a good way of kind of simplifying it in terms of a very practical approach?
I love Sergio. That's perfect. I couldn't say better.
So as we close, Andre, just to putting everything together for the bedside clinician, could you talk about common pitfalls to avoid in treating pneumonias in the ICU based on what you've seen throughout your years of practice and being consulted on many of these cases?
Yeah, I would say, in a nutshell, Sergio, I would say that your clinical assessment is going to be really the key point for most of these patients. Your initial clinical assessment. Do never rely on a single chest X-ray. Never rely on a single a laboratory marker. A normal chest X-ray does not rule out pneumonia. A normal biomarker in the blood does not rule out pneumonia. So I think that would be the very common pitfalls that I would say that you should avoid, because I've seen that so many times. People are saying, well, I don't think this patient has pneumonia because the chest X-ray is normal. And then you wait a little bit, and you do another chest X-ray where you do a CT scan, and you're going to see rip-roaring progressive pneumonia. So never fall into this kind of traps. The same with the white count, CRP, Procal, whatever BSL, whatever you have in your hospital. None of these things are going to rule out pneumonia. I would say these are the things that I want you to never forget. That single factors like this will not change the fact that if your pre-test probability, your suspicion is very high based on a history and a physical examination, everything else is going to take second place. That would be my, kind of my, best advice to not miss. Because once you miss this, once you decide to not give the proper antibiotics or supportive care because of one of these things that is misleading you, likely the patient is going to have a worse outcome.
Excellent. Any pearl of wisdom you want to add?
What I would add is that in complement of the pitfalls here is that nothing ever is going to replace your clinical judgment of putting all these factors together. Sergio, but I really believe that the best clinician, the best ICU doc, the best ID doc is the one that put the pieces together. And I'm going to repeat this until the last day of my life. I really think that there's no replacement for critical thinking. There's no replacement for a critical analysis in continuous analysis, understanding of what's happening with your patient. You really have to be seeing your patient in a very, very, very close way, because there's no other way for you to find out why a patient is improving or not improving from a severe pneumonia, which we already talked is the number one cause of sepsis in every ICU in this planet.
Andre, you've been on the podcast before. We like to close with a couple of questions that are unrelated to the clinical topic. Would that be okay?
Yes, absolutely.
So the last time you were on, we talked about books. Today, I'd like to ask you a little bit about music. If you had to take one or two music albums for a long trip or an extended isolation period, which would they be?
Well, I'll tell you, I have so many, but it's going to be hard to it's going to be hard to choose. But I'll give you just a couple of. I'll just do two or three if you don't mind, because it's hard to choose, because I almost feel like I choose among kids. It's like they're all good. They're all good. I don't want to say one is better than the other. So I'm gonna give my first one. I will give you that is I absolutely love, and I've seen him alive twice. Is a guitar player called Pat Metheny. He's originally here from Missouri. He's very close. He started playing in Kansas City, and nobody knows exactly what he plays. And they call them in jazz fusion, whatever. He got many different prizes from different styles of music. He plays all styles of music, but he primarily is an incredible guitar player. And very creative. His music is just lovely, pleasant, very intelligent, and fun to listen. So it's a great combination. So there's one album. He has many albums, but there's one album in particular that I like to hear as a way to get myself out of the sometimes of the crazy things that we face in life. Is called We Live Here. We Live Here. It was an album from 1994. The other one that I have to tell that I cannot get tired of listening, and that's based on the fact that I grew up listening to him when I was living in Brazil. When it's an album from Antonio Carlos Jobim, the father of Bossa Nova. There's an album called Terra Brasilis, Terra like Earth, Terra Brasilis from 1980. It's a double album. The LPs that I had in the past, I don't have LPs anymore, but I can tell you that is. The entire album is just so much fun to listen. He's so creative. The music is so beautiful. So Jobim is clearly, to me, one of the fathers of Brazilian music in modern times. And the third one I want to tell you that it goes in the classic world, but I also listen very, very frequently. Gustav Mahler. Anything from Gustav Mahler is good, but if somebody wants to get started in Gustav Mahler, I would suggest to start with Symphony Number 9. There's a album from the Chicago Symphony, I think the maestro is Claudia Abbado. There's one album that's specifically from the Chicago Symphony that has the Mahler Number 9. It's just you don't need to know anything about classical music. You listen to that music and you fall in love. I mean, he is just an incredible composer. So I'll stop here. Otherwise, we're going to be talking for another hour, Sergio.
Well, I think it's a beautiful list, and I obviously familiar with some of it, but I can't say I'm a Pat Metheny expert, but I have some of his albums, and Carlos Jobim, of course, is an icon of bossa nova and of music in general. But what I would say, Andre, very appropriate for our conversation because this is a very broad spectrum approach. So I think it's perfect.
That's funny.
Yeah. So the second question is if you could share something you have changed your mind about in the recent years.
Yeah. So, Sergio, I would say that it was an evolving process. Is that, and I believe that when I have that, that kind of strong diagnostic, feeling that the patient has severe pneumonia, either severe CAP or a VAP. I learned through the years that it make a difference to really be aggressive and start antibiotics, not kind of lingering around to see what's going to happen in somebody that ill. Not only timing, but dosing. The two things that I adapt and I changed through the years, I'm much more aggressive about starting antibiotics in these patients, and I'm much more aggressive about using prolonged infusions. We don't use a lot of continuous infusions, but I've used that for years, and I felt impressively happy with the paper that was the Blink-3, that was the RCT just published in JAMA recently. There was this Australian multinational trial showing that actually, I think it was over 100 different ICUs in the world. I mean, impressive, 7,000 patients. I mean, I think in our lifetime, we're not going to see another RCT that well done. And unquestionably, the use of beta-lactam, extended infusion beta-lactam, meaning that you're going to use for, something in the range of 3 hours or so, 3 to 4 hours every dose. That means when you give the beta-lactam to patients with, in this case, was sepsis, but again, as I told you, most of these patients with sepsis are going to have pneumonia or intra-abdominal infections. They had a better survival when they use that, because especially with the beta-lactams, you can, the longer you are above the MIC, the more effective is the drug. So I through the years, I learned that the 30 minutes infusion that we grew up doing the ICUs are not really that good anymore. And again, you need an infusion pump, you need a nurse that knows what to do with this. So if you don't have this, you better give the 30-minute infusion. But if you have the minimal infrastructure to do this, I learned through the years that timing of initiation of antibiotics and dosing of antibiotics are absolutely critical to save lives, and I evolved to be much better with this today, Sergio.
Excellent. Finally, to close, is there any closing thought, quote, or thought that you want to share with our audience?
So, what I would say is, Sergio, that, all of us that deal with critically ill patients, and when it comes to infection, I want you to always remember that different from cardiac disease and disease that have a much more physiological approach, when it comes to acute infection, it is a critical illness that is nonlinear. Greg, I know it sounds a little nerdy and a little bit nuanced, but it's really important. Because when you have an acute illness, let's say a heart failure or myocardial infarction, you know exactly the point. Okay, when you're going to give thrombolytics, what's happening, you have the EKG, everything follows a linear pattern in the ICU. When it comes to infection, nothing's linear. That's what we call complex biology or nonlinear biology. And why this is important? This is important because there will not be any replacement for the ICU doc to use critical thinking in order to really make the best decision for these patients with acute infections. So I think my last message that every intensivist should know is that your clinical experience, your critical thinking, your bedside judgment is going to be more important than ever to treat acute infections, especially in this complex world where we are seeing new infections and more patients with different host response, different immunosuppressive drugs. Your critical thinking is going to be more important than ever. So never undervalue your skills and the importance of your skills to save patients in the ICU. This is never going to change, and I truly believe that this is the best asset we have in the ICU today.
I think this is a perfect place to stop. Andre, thank you so much for your generosity with your time and sharing your expertise. Always a great conversation, a lot to learn from. And we'll link a lot of the articles that we discussed in the show notes. It would encourage our listeners to look them up, and also a link to all those wonderful albums and music that you recommended. So look forward to having you back soon. And until then, be well.
Thank you so much, Sergio. I'll be always glad to be back. Have a great day.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.